Hello, I'm Dr. Brian Cole, and over the next few minutes, I wanted to discuss the management of symptomatic articular cartilage defects in our athletes and the decision-making required to manage these individuals. It is not uncommon that we see relatively young people with relatively advanced disease, such as we see here in an NBA player who in the lateral compartment has a degenerative lateral meniscus tear and lateral tibial plateau disease. We also know that our young athletes, when active after a meniscectomy, something quite simple, may end up getting progressive degenerative disease that's even bipolar in nature, as you see here in this Division I soccer player. The decision-making is very different in some of our active individuals, including the sports that they participate in, because it involves not just the cartilage defect itself, but all the other variables, such as the bone marrow, ligament injury, ongoing stress, things related to contract year, and so forth, as well as their ultimate symptoms that as they present and potentially limit their participation in play. What's also particularly interesting is we don't fully understand why individual athletes may hurt. We know that it's very common for MRIs to show asymptomatic individuals to have articular cartilage defects. We also know that MRIs can often underestimate the degree of disease that we might see at the time of arthroscopy, as we see here in this trochlear defect with significant delamination. In general, with active individuals, we may see cartilage lesions in the range of 41 to 81%, as well as meniscal lesions at 20 to 75%. What's even more fascinating is if you take these relatively young active patients and we say, well, how frequently does it happen in our population, in the non-hyper-athletic population, we see that these individuals are in the ages of 30 to 40 years when we compare the incidence of their disease to those in their 20s to 30s. So there seems to be an advancement in the absolute incidence of this disease in our relatively young patients. Patients will always ask us, say, look, will sports participation make it worse? And there are a number of studies that have shown that participation in sports did not necessarily correlate with the progression of disease. The things that we found were that obesity and a previous history of knee surgery or injury might relate to the hours of sports as it leads to disease progression. What's even more perplexing, however, is the fact that untreated cartilage defects may have a very innocuous natural history. In this study that looked at patients who had ACL injury and an index cartilage defect at the time of that ACL injury, they didn't appear to be that much different at 10 to 15-year follow-up compared to a cohort of patients who were treated with an ACL reconstruction where their defect was absolutely neglected compared to those who didn't have a defect at all. So it begs the question of this concept of skillful neglect. And this is a great quote by Voltaire: "The art of medicine consists in amusing the patient while nature cures the disease." Many of our patients really just need reassurance, and it goes a long way because we're often just managing anxiety and uncertainty. What's critical is that unlike other types of treatment that we offer in our office setting, we have to manage patient expectations. It can be especially difficult in patients who are very, very active with high demand levels. Many times, this is more of a light rheostat that down-regulates their symptoms, allowing them to have less discomfort and more performance, but they are often not perfect after engaging in treatment. So when we're managing our highest level athletes, it's very important to separate concern from disability. The inability to perform often makes them unemployable, and the treatment chosen may actually affect their asset value. We're very good at improving activities of daily living and less so at our ability to predict return to sport. It's also important to match the solution that we decide through consensual decision-making to the anticipated outcome that that athlete desires, as well as to match their time frame. We often need to choose solutions that don't burn important bridges. What's really fascinating is that we can get an athlete after cartilage repair back to sport if they're able to endure a predictable return to play for more than a year. That often predicts the next couple of years and their ability to continue to play with minimal symptoms. So then the question is, who gets what? Non-operative treatment is quite good for those who have acute onset of symptoms where their performance is maintained, or if their performance is compromised and they're willing to push through it. Alternatively, operative treatment is often recommended for those where performance is impaired, they failed non-operative treatment, and maybe they're early in a long contract. Now, there are a variety of surgical options available, and these are the incidences, the relative frequencies of each of these options. Debridement still remains the #1 treatment that we offer our patients with early symptomatic disease. But as we move along the lineage, it may include marrow stimulation, surface cartilage transplants, osteochondral autografts, autologous condensate implantation or MACI, as well as osteochondral allografts. And how we decide depends upon a number of other variables, such as are they in mid-season where they develop mechanical symptoms? That may respond to debridement. However, the patellofemoral joint may be best treated with debridement leading up to marrow stimulation for smaller defects. We often will supplement that with adjuncts to marrow stimulation. Small defects and large defects, either the patellofemoral joint or the tibulofemoral joint, are often treated differently. We've looked at our patients who have undergone debridement, and what we found is that those who were intended to undergo autologous condensate implantation, about 40% of them never required implantation because they actually got better from their debridement. This is an example of an NBA player with a history of patellofemoral disease. He has ongoing symptoms. He's in his second season, has this history of left knee cartilage injury. He underwent a previous debridement and loose body removal during his senior year of college, but he has new onset of symptoms. We took a very basic approach. Obviously, with imaging, you can see that the patient has a patella defect, as you'll see here as we cycle through the sagittal images, as well as the axial images. And it seems to be a unipolar defect. At the time of arthroscopy, the patient had simple debridement of this patella defect of the delaminated fragments and underwent bone marrow aspirate harvest and concentration with injection to potentially provide mediators to reduce inflammation. This patient actually has done well. He's actually more than 2 years out, continues to play with no further knee complaints following the simple debridement. Now, marrow stimulation is another option that we can offer athletes, and the reports will suggest that we can achieve excellent results as long as rehabilitation is adhered to and the procedure is performed judiciously with proper surgical technique. When you look across all high-level sports, you see very good return to sport in our athletes. I think the critical thing with marrow stimulation is that it involves drilling, good defect preparation, respecting the rehabilitation, and also addressing comorbidities, just like we will with any other cartilage repair procedure. This is a 20-year-old college athlete who has a focal defect with some subcondylar edema. It's a relatively small defect, but the area of injury, if you include the subcondylar edema, is probably much larger than what we'll see arthroscopically. And indeed, at the time of arthroscopy, the defect was pretty narrow, and we performed a marrow stimulation technique. You can see this one wouldn't be a great one for an osteochondral autograft because it's very narrow and long. And there's nothing really to debride in this instance that would lead to an expectation that that patient would get better. And at the same time, we use bone marrow aspirate and concentration. We know now that we're doing better with marrow stimulation with drilling. In fact, in our study, we showed that there was a much lower revision rate in patients who underwent marrow stimulation when we drilled versus using a traditional microfracture awl. Another procedure that we frequently use is something called AutoCart. This is a single-stage cartilage procedure where we'll go into the intercondylar notch and actually obtain articular cartilage, as you see here. And that articular cartilage is actually pulled into a receptacle called a graft net device, as you see here. And we may use platelet-rich plasma. We may combine it with collagen, so-called BIOCARTILAGE, which is allogeneic collagen, to augment the marrow stimulation technique. Now, this is a case example, a 15-year-old with a lateral femoral condo osteochondritis dissecans lesion. You can see some cystic change along the lateral femoral condyle. At the time of arthroscopy, the debridement is performed. We then go to the intercondylar notch, use a 5-0 shaver to capture articular cartilage fragments. These fragments are collected. They are then combined with bone marrow aspirate or PRP to create a slurry with an adjunct of allogeneic collagen. This is the defect that's being debrided. We may drill it to stimulate some healing. So this is the mixture: biocartilage, which is allogeneic collagen coming from articular cartilage, platelet-rich plasma, as well as the articular cartilage that we harvested from the intercondylar notch and captured into the receptacle. Arthroscopically, we can inject this mixture into a paste into the defect, and then at the end of the procedure, we'll cover with fibrin glue. As you see here, this can be performed completely arthroscopically virtually anywhere in the knee, and it's an excellent solution for tibial defects, which really don't offer a variety of treatment solutions in that setting. We know when these minced fragments are processed that there's very good cell viability. We tend to see apoptosis at the edges of these individual fragments, and matrix is produced. Moving along the lineage, we know that osteochondral autograft now is a dominant treatment strategy for small defects in the neighborhood of 10 to 11 millimeters. In fact, comparisons to marrow stimulation suggest that there's about a 96% success rate in some of our studies compared to marrow stimulation, which offers about a 50% success rate. But again, these are very small defects. We also know that survivorship can be quite good at 10 years and beyond with improvements in symptoms. This is a case example of a lateral femoral condo defect in another collegiate level athlete. She had a previous knee debridement and loose body removal and just has this 1 centimeter defect. In my mind, this is a perfect defect to perform an osteochondral autograft transplant, as you see here. She also has a bit of tibial disease. This is a treatment pathway that involves simply taking a non-weight-bearing area of the lateral trochlea and transplanting it to the weight-bearing zone of that where the defect exists or is deficient. An osteochondral allograft is still my mainstay for treatment. We use it virtually in any location in the knee except for the tibia on any frequent basis. This is a fresh graft harvested within 24 hours of asystole. We also know that we can treat very large degenerative lesions with multiple plugs or a so-called BIOUNI, where we can use an oblong instrumentation to create matching defects to the convexity of the femoral condyle. Return to sport after osteochondral allograft is actually very, very good and quite predictable. We see return to sport in the neighborhood of 75 to 88%. Another case example of an athlete with a fairly significant defect of the lateral trochlea and the femoral condyle, as you see here. This is a hockey player who had a large trochlear defect, and these can be particularly technically challenging. You see sort of a butterfly-shaped defect here. We performed a fresh osteochondral allograft in an open setting through a lateral retinacular release. It's important to understand that these athletes present not just with cartilage defects, but also with malalignment and meniscal deficiency, and that weighs into the treatment and decision-making. When we add a meniscal allograft to the process of treating patients with articular cartilage disease, we also know that return to sport rates can be quite high in the neighborhood of 75 to 85%. So it speaks to the fact that these patients don't just present with a cartilage defect, but also we need to manage all aspects of their knee, including meniscal deficiency, as well as malalignment. We know in our series and other series that we can return high-level athletes with osteotomy, correcting very mild varus or valgus abnormalities. This is an example of an NFL lineman with a varus deformity who's missing some of the meniscus and has a focal cartilage defect of the femoral condyle, who underwent an osteochondral allograft transplant of that defect along with an osteotomy. We have a number of individuals in very high-level sports have been able to return following this combination. Another example of a soccer player, similar type defect on the lateral side, undergoing a distal femoral osteotomy to correct valgus disease. Finally, we often will use orthobiologics, but there still remains a paucity of high-quality studies. We've learned recently that the use of bone marrow concentrate at the time of an osteochondral allograft may actually encourage bony healing at the level of the host donor recipient socket. So the preliminary results are quite encouraging. So just a few key takeaways. There's a large incidence of cartilage abnormalities that may never actually lead to symptoms. The plan that we choose must meet the athlete's expectations of pain reduction and improve performance, but it's generally not considered preventative. Skillful neglect is an acceptable form of treatment for many of these because we don't have a good understanding of the natural history, and many of these defects will not cause symptoms. But in general, in treating our highest level athletes, we do the least amount necessary to achieve a successful outcome. Thank you very much for your attention.